I'm Annette Sachs-Robertson with UNFPA Asia Pacific Office. And as moderator of the panel, I'm really delighted to introduce our panelists for this session. We're on an exciting road, actually. I think with the extremely interesting studies that are going to be shared with us today on measuring scales of quality of care, particularly in counseling and family planning. We're hoping that it'll generate a lot of discussion. So our first speaker is Dr. Kelsey Hall, who is a social and behavioral scientist and associate professor in the University of California, San Francisco. She conducts research on individuals' preferences for and experiences with reproductive health care, and designs and evaluates innovation and innovative approaches to improving reproductive health and autonomy. She's currently leading projects in the United States and in 7 low and middle income countries. So I'm going to hand over to Kelsey now. Thank you.
Thank you so much. It's a pleasure to be here today to talk to you about the quality of contraceptive counseling scale. So by way of background, I wanted to share a little bit about the genesis behind this project, which was actually almost 10 years ago at the 2013 ICFP in Ethiopia, which I'm sure many of you were also attending. I was at the conference as a doctoral student and really inspired by all the energy and action. It was the year after the 2012 London Summit. And at the same time, feeling a bit uneasy and concerned about what was happening that year with sort of the focus on implants, the focus on postpartum IUD, and kind of the push for provider-controlled methods, which many were concerned was going to have unintended negative consequences for autonomy and informed choice. And so a sort of light bulb moment went off for me at that conference where I realized that there was a huge gap in our available measures for understanding people's experiences with counseling, and that at the same time I was learning in my doctoral program about how to develop scales. And so I thought, hey, this is a great opportunity to fill this gap and really try and innovate measurement in this area. So bolstered by one of the Packard Quality Innovation Challenge grants that year, was delighted to be able to start this line of work and really happy to share it with you all today, presenting on behalf of amazing teams in Mexico, India, and Ethiopia. So we began the work, as with any good scale development project, by defining our construct. So we published in 2017 the measurement framework to define quality in contraceptive counseling. Then began original research in Mexico, first to document what people wanted in counseling, to start with qualitative formative research to understand what really mattered to people when it came to quality in counseling, and then subsequently developed the item pool and validated the first version of the QCC scale in Mexico. And then the work I'll be presenting today is our adaptation and validation of the version of the scale for India and Ethiopia. So in those settings, we replicated what we'd done in Mexico, started with qualitative formative research to understand people's preferences for counseling, and then based on that, adapted the scale and validated it. And I also want to just mention, concurrent with this, we've been reducing the QCC scale to a 10-item version. I hope you'll come see our poster tomorrow for more information on the 10-item version. So the original QCC Mexico scale has 3 domains. You can see here, the information exchange domain, the interpersonal relationship domain, and the disrespect and abuse domain. So to adapt the scale for India and Ethiopia, we started by taking the original item pool from Mexico, translating it, of course, and then starting to think about what we'd seen in the formative research and contextualizing and changing some of the items to be more relevant for the 2 new country contexts. And this included adding 4 new items and changing one of the age discrimination items from Mexico that wasn't as relevant for India. So some tweaks at this stage. At this point, I want to just show you a few examples of our scale items. So you can see we have the 3 domains represented here. In the information exchange subscale, the first item is an example of items that cover the part of the construct that are about information provision. So the item says, I received complete information about my options for contraceptive methods. So you can see this is really from the person's perspective, Not did they learn X, Y, and Z, but did they feel like they got what they needed? This subscale also has items like the second one that are more about the kind of personalization, which is part of high quality counseling. And so this item reads, the provider asked me questions in order to provide counseling that fit my personal experience. And that was one of the new ones we added for India and Ethiopia. In the interpersonal relationship subscale, we have questions such as this one. I felt encouraged to ask questions and express my concerns. And then in the disrespect and abuse subscale, this is an example of an item that gets at pressure and coercion. It says, the provider pressured me to use the method they wanted me to use. After we had contextualized the items, we did some cognitive interviews, made some final tweaks, and then ultimately had an item pool of 26 items per country that were fielded. So at a high-level overview of the validation methodology here, we conducted dedicated studies in India and Ethiopia for the purpose of developing and validating this measure. So you can see in Ethiopia, we were in the capital, in public and franchise sectors. In India, we were in Vadodara in the urban and rural public sector. And luckily collected all the data right before the pandemic. A high-level overview of the analysis. We did separate psychometric analyses in each country and triangulated what we were finding from quantitative indicators of the scale performance and item performance, with ultimately running everything through the lens of content validity. So to what extent were we able to maintain the full range of the measurement construct as we decided which final items would be in the scale. For the psychometric analysis, we did both classical test theory and confirmatory factor analysis. Because the items actually remained quite similar between the three countries after adaptation, we chose confirmatory instead of exploratory factor analysis to be able to see the extent to which we could find evidence that the domains were the same and that we were able to find evidence of kind of a similar structure across countries. And also looked at convergent validity to see the degree to which our QCC scores were related to a single item experience measure, as well as in Ethiopia, we collected information from those who had selected a method. We asked them if they planned to actually start using it as sort of a person-centered measure of whether or not somebody's needs were met in the counseling experience. Okay, so our results. Our samples across the two settings are reflected here. You can see we had on average 27, 28 years of age across the two countries, majority married, a little bit of a more highly educated population in Ethiopia compared to India. And this last one I want to just mention, the QCC scale, we designed it so that the items work for people who are returning clients, new clients, people who are there for removals. We really took care to make sure the items would work for anybody who has a discussion with a provider about their options. So as you can see here, particularly in Ethiopia, a majority of the people who took the survey were already using a method, and most of those were using injectables. Okay, so first let me show you just kind of how our scores shook out. And in a moment I'll mention, a few items that were removed and such, but this is showing you the final scale in each country, the average scores. And so the QCC scale, we decided to calculate a simple average for ease of people using it in kind of program contexts. We didn't get into any fancy item response theory or anything like that to calculate scores. It's just a simple average on a scale of 1 to 4. 4 being the highest, and so disrespect and abuse subscale items are reverse coded, so this is reflecting low percentages of people reporting very negative experiences. You can see overall the scores were slightly higher in India than Ethiopia, except for the disrespect and abuse subscale where we saw slightly more women in India reporting those more extreme negative experiences. Okay, so our psychometric analyses, the high-level takeaway here was that we found that both countries' data fit well with the original 3-factor structure. So the 3 scales are tailored to the context, but retain that dimensionality that I showed you at the beginning. The factor loadings, the large majority of items in both countries loaded well over our 0.4 threshold. You can see here we did retain a few items, particularly in India, that didn't load at that 0.4 threshold, but we decided to keep them because they were important from a content validity perspective and because they didn't seem to bring down the overall alpha. And so at a kind of reliability level, we were able to keep good psychometric profile while keeping a couple of these items that weren't loading so well. You can see in the middle here that we had good reliability, particularly in Ethiopia. And then related to skew, it's important to mention that the overall scale and the information and interpersonal subscales, we didn't find evidence of skew, and so those can still be calculated as averages across the items. However, the disrespect and abuse subscale was highly skewed, and so when folks use this as a standalone measure, which you can do because it's a standalone subscale, we recommend dichotomizing it. So basically, yes or no, anybody reported any degree of disrespect and abuse. Because of the skew, that subscale should be calculated as a dichotomous score. Our convergent validity results you can see here. So what you're looking at in the rows are the different outcome variables that we regressed QCC scores on. So this first green box shows you India, where we found significant positive correlations between the QCC scores and a single item measure of experience for all of the scale and subscales except for the disrespect and abuse subscale. In Ethiopia, all were significantly positively correlated. And in Ethiopia, where we had this additional variable about whether people intended to use the method that they selected or were provided, we also found strong positive correlations. And I want to mention here, people often ask, well, if your score is highly correlated with a single item measure of experience, why don't you just measure one item of experience and not a 22 item or 23 item scale? And so just quickly, I want to say, that's true. However, the benefit of having a scale, of course, is that you have that granularity of the subscales and the specific items where you can see if there are deficiencies in quality. These are the particular areas, whether it's a subscale or even a particular item where people are reporting not so great experiences. Okay, so to wrap up here, the takeaway is that we were happy to see from the analyses that the psychometric properties were good. And so these are valid and reliable scales ready for folks to use in your settings. We had particularly strong psychometric properties in Ethiopia. So interestingly, as I already alluded to, the majority of the items remain the same across settings. So, we invested in a really methodical process over the years to do formative research and to adapt the items for each setting, which was really valuable. And interestingly, it turned out that across settings, people had a lot of the same preferences for how they wanted to be treated in counseling. And so the takeaway from that is that we both have slight differences in these scales, so there's different options that people can use, but also if you're from a country where that's not represented here, likely the scales are pretty easily adapted or transferable given what we've seen across these three continents in terms of what really matters to people in counseling and how these scales are performing. The main area where we did have kind of differences was around the interpersonal relationship subscales. So that's where a lot of the contextual differences really played out. Salient forms of discrimination varied a little bit between settings. And again, the items that we kept that weren't loading as well as we would have liked were, in India, for example, the items related to privacy, volunteerism, that pressure item I showed you, which we thought were extremely critical to the overall content validity and hence retaining those. So in conclusion, these scales can be used in both research and programmatic contexts. There's the 3 different validated versions now. And they can be used as standalone subscales if you have a particular interest in looking, for example, at disrespect and abuse or at interpersonal relationships, or they can be used as a composite score. And I will just highlight that, one of the things that I think is unique about this scale is the disrespect and abuse subscale. There's been so much innovation in the last 5 years or so in quality measurement, which has been so exciting to see. So I just wanted to point out that I think one of the things that sets the QCC scale apart is this disrespect and abuse subscale. And And then just to end by saying we have a new website, please check it out. Again, we have this 10-item version too that we've just worked on reducing, and happy to have you come see our poster tomorrow. I want to end by just acknowledging the incredible teams I've had the privilege of working with across the settings that we've validated the scale in. So in Ethiopia, St. Paul's Hospital, Millennium Medical College, in India with CORT, and in Mexico with MexFam. And huge thanks to the Packard Foundation for supporting us all these years. Thank you.
Thank you so much. Thank you so much, Kelsey. Thank you for sharing with us the adaptation and the validation of the QCC scale in India and Ethiopia. Really interesting to see the high consistency and internal reliability in both settings and the findings that you have. Ladies and gentlemen, in the interest of time, I'm going to ask that we hold our questions until the end. We'll have all the presentations, and then we'll have the questions at the end. So now I'd like to introduce our second speaker, Dr. Martha Silva, who is an assistant professor at Tulane School of Public Health, and serves as a data strategist and innovation team lead for the Breakthrough Research Project. She works in the fields of social and behavioral change research and health services research. So I'd like to hand over to you, Martha. Thank you.
I'm actually wondering, is it okay if I present from here?
Yes, that's fine.
Do you have, how do you?
I think it should be okay. You want to talk?
Hello? Yes, thank you. Thank you so much. Thank you very much. Good morning. So today I'll be spending a few minutes describing a scale development process that we undertook as a part of the Breakthrough Research Project. And this to measure provider attitudes, and particularly attitudes that could be relevant across different health areas. The impetus for this work was that we recognized the need for more robust measurement of the factors that influence whether and how providers provide high-quality care. The Breakthrough Research Project is, in its first year, was engaged in a multi-step collaborative process to define and prioritize research and learning agendas to advance social and behavior change evidence-based programming. So the image that you can see on the right corresponds to the research and learning agenda for provider behavior change, which was one of the identified priority areas in this process that was led early on. One of the key gaps identified by a range of stakeholders and social and behavior change practitioners was related to measures for provider attitudes. So the guiding question that this research and learning agenda provided was, how can we best measure provider attitudes that influence their performance and adherence to timely and respectful client-centered care practices? So we began this work by adapting Tavro's framework that explores how providers influence service use and the client's experiences with services. We were particularly interested in exploring provider attitudes that could apply to multiple health areas, as I already mentioned, and based on early literature reviews that Breakthrough Research conducted, we decided to focus on 3 conceptual provider attitude domains, which were perceptions of clients, attitudes towards their professional roles, and attitudes related to gender roles as well. So this is an overview of the process to date, which can be divided into 3 phases. So as I mentioned already, we began almost 4 years ago now, first relying on literature reviews to develop quantitative survey items related to 3 domains that I mentioned. And important to note that this process was leveraging studies that were already planned with partners. And so very quick process that was really making good use of opportunities that were presenting to us. And so in partnership with D4I, which is another USAID funded project, we fielded 23 survey items items that were developed based on this literature review in the Democratic Republic of Congo, DRC. And so this was as part of a facility survey that was already planned as part of a larger study where we were able to field these 23 survey items. This included a sample of 1,143 providers in 460 facilities, but when we conducted the reliability analyses, we found that our survey items were not working well as scales. So then we moved on to phase 2, which was also in collaboration with another USAID-funded project, this time Breakthrough Action. And we refined the survey items through qualitative cognitive interviews to understand how providers were interpreting both the questions as well as the response options, and which allowed us to make several improvements, and then move on to a third phase where we fielded these updated items to achieve a more reliable scale. It's worth mentioning again that this scale development process was health area agnostic, meaning that the scale could be applied to providers that were working across multiple health areas. However, the study that we utilized in the phase 3 was a family planning specific study, and so therefore the results that we're discussing here to show the utility of the scale are family planning oriented. Also important to note that all 3 phases were carried out in French. So as I mentioned, in phase 1, we interviewed over 1,000 providers, but found pretty low response variability in more than a third of the survey items, and also low internal consistency in this scale. So we moved quickly on to phase 2, as mentioned, in partnership with Breakthrough Action. And in phase 2, we conducted these cognitive interviews with providers, and really to help us better understand the content and the construct validity of the items and identify updates that we could make to the survey items. We were looking to better capture the intended measurement objectives and also to make them clearer to the respondent, or potentially modify the wording to be able to capture greater variation in responses and to reflect the spectrum of provider attitudes that we could find in these contexts. Here are some examples of how we analyze the cognitive interview data to help us reflect on how to update the survey items. And so, because this scale is meant to capture provider attitudes that might influence provision of care, a lot of the updates were in the sense to inject more subjectivity into the questions or to refine the question to be more specific and clear for respondents and capturing attitudes. So overall, we made updates to 17 of the 23 items, and then we moved on to phase 3 of the process, which included these revised questions, which were fielded as part of, this time as part of a breakthrough research study that was already planned and to be fielded in Togo. So we moved the context of this development process from the DRC to Togo. And this was part of a facility-based survey with providers of family planning in different districts, mostly urban and peri-urban in Togo. We found that the revision did help to increase variability in the survey items, and ultimately, based on the number of scale development criteria, including factor loadings, we retained 14 of the original 23 items. So these 14 items loaded on a single factor, indicating there are original conceptual domains of perceptions of clients, perceptions of or attitudes towards professional roles, as well as attitudes related to gender roles, were not really themselves latent constructs underlying provider attitudes, but they were elements of each of these domains that were represented across the 14 items that we retained. In examining what these 14 items did represent, and also with the help of peer advice and a high-level review of the literature, we landed on the concept of authoritarian attitudes, which emerged through these 14 items that we retained. So as mentioned, while the original conceptual domains were not individual latent constructs, These questions from each domain that we retained in the 14-item authoritarian attitude scales did include each of the 3 originally identified domains. So for example, one should treat patients with respect even if they don't treat me with respect was originally conceived under the perceptions about clients domain. Another example, so under attitudes about their professional roles, we retained these survey items that you can see here, including, I have the responsibility to ensure that patients have a say in their care. I won't read the rest in the interest of time, but yes. Under attitudes about gender roles, we retained the items that you see here. An example, a man should have the final say on decisions made in his home, which was included in the attitudes about gender roles domain that we had originally developed. So now that we have a scale that measures authoritarian provider attitudes, we needed to explore whether these attitudes are important and how are they important, what are they associated with. So we used the data from the Togo study that we had leveraged to field these survey items. And what we're showing you in this slide is the association of provider attitudes as measured by the 14-item authoritarian attitude scale. With beliefs about equitable FP services and perceptions of FP service quality in a provider's facility. So the higher a provider scores in authoritarian attitudes, that is, the more authoritarian their attitudes, the lower they score on their beliefs that FP services should be provided equitably to unmarried women and women without children. Similarly, the more authoritarian the provider's attitudes are, the lower the scores on their perceptions of the quality of FP services that the facility provides in the provider's facility. So to close, we started down this path of developing a validated measure of provider attitudes that had the potential to be applicable to multiple health areas. And we wanted to better understand the attitudes that, among other things, would influence providers' behavior and can affect healthcare provision, and in turn affect the client's experience with services, uptake, and continuation of care. We need to continue testing and validating these measures in other contexts, but so far we have identified reliable measures of authoritarian provider attitudes. So next steps also include doing further analyses with the data set in Togo to link provider data with client data and explore the links between these provider attitudes and client level outcomes, which is a really important step. In the meanwhile, these survey items measuring authoritarian provider attitudes are available for incorporation into future surveys with providers. And we have developed a short user guide, a technical guide that is available that we can happily share. And I really look forward to questions and further discussion. Thank you.
Thank you so much. Excellent. Ladies and gentlemen, we've heard another measurement of scale on really trying to look at provider behavior change and how it can be improved, especially in the relation to counseling and how it's been adapted. Looking at, of course, the authoritarian attitudes in this particular case. I'm going to now ask our third speaker, Dr. Zahir Gul, who is the Senior Technical Advisor for Social and Behavior Change and Health Markets with Pathfinder. He also leads the Pathfinder portfolio of private sector development initiatives under the USAID Frontier Health Markets Engage project and specializes in health systems and policy. His technical focus has been cross-cultural application of behavior theory for predictive behavior modeling of behaviors using psychometric measures. I'll hand over to Dr. Zahir now. Thank you. Thanks, Zahir.
Thank you, Annette. Okay. So, those were 2 hard acts to follow. In the interest of time, I'm going to go off script, but let's see if we can get the message across. So to start off with this work, I'd like to share a little bit about the background of the impetus for this work under the Beyond Bias project, which was a response to the need for more structured evidence-based provider behavior change interventions, moving beyond the traditional training and value clarification work that's been done typically for the last many, many decades. And the aim of Beyond Bias was to really address the barrier to contraceptive uptake for adolescents and youth, particularly in the last meter of care during the moment of consultation with providers. We know that bias exists, it's alive and well, yet there are challenges around how to address it, how to measure it, or how to detect it, or whether it should be detected at all, and we should be looking at person-centered care instead. So in response to that, the Beyond Bias project came in to design and test scalable, innovative solutions to address provider bias towards serving youth ages 15 to 24 with family planning services in Burkina Faso, Pakistan, and Tanzania. And as this sort of flow indicates, that this formative phase for this work was a good two and a half years long, which consisted of formative working, human-centered design, prototyping, testing of those live prototypes, and then taking the promising solutions to the piloting and evaluation phase. The work was done in 3 countries across a universe of about 227 facilities. I'd like to describe the intervention a little bit. The theory of change really is predicated on 3 core pillars of the intervention: Summit, Connect, and Rewards. Summit was, in essence, a bringing together of the provider network in one event to introduce, mobilize, and then engage subsequently through Connect, which was a series of interactive activities consisting of in-person or virtual, or in some contexts, at least in Tanzania, it was a mix of virtual and in-person interaction. Finally, the 3rd pillar was rewards, where providers' performance in terms of the key behaviors to promote were linked to incentives, non-financial incentives, typically recognition, which fed into the rewards pillar. The outcomes that Beyond Bias identified through the formative work, and this is important because if you're going to change behaviors, you need to know the specific behaviors that you must promote. For providers in this entire process of consultation, Beyond Bias identified 6 key behaviors as referred to as the counseling cascade, or the 6 principles framework, specifically sensitive communication, safe welcoming space, seeking understanding and agreement, security of information, saying yes to a safe method, and simple comprehensive counseling. Now, based on that, we had a list of learning questions within the project, and one of them was that what client-level outcomes can be reliably attributed to the Beyond Bias intervention when operating at scale. And the rationale really was to link perceived person-centeredness of these client-level outcomes to the Beyond Bias theory of change and the counseling cascade under the 6 principles framework. Of course, the work was also aimed at accounting for and removing measurement error from these client-level latent outcome variables. And finally, ease of implementation of these scales within a program to inform the rewards pillar and linking the rewards pillar to empirical data from the program itself. Our core research objective was to develop a reliable scale informed by the Beyond Bias 6 principles of client-centered care framework to measure exposure of the client to person-centered family planning care. So as a first step, the team undertook a description of the causal pathway and outcomes, adding to the original theory of change. Of course, the intervention is assumed to influence provider-level latent variables, which underpin bias. So attitudes, of course, underpin that, followed by observed outcomes related to quality of service delivery. For Beyond Bias, these were the 6 principles of practice that providers were observed and assessed for. And of course, that leads to the provision of a method of choice to the client. In order to understand what the client-level outcomes were, we hypothesized one latent variable at the client level, which we referred to as perceived person-centeredness of services. And for this particular study, this highlighted pathway is what became the realm for inquiry and subsequent analyses. To unpack this highlighted component, as you can see, each of the 6 principles had clear behavioral definitions, and in trying to hypothesize a framework for analysis and develop a measurement framework, we did something very simple. We hypothesized that each of these 6 principles of practice would emerge in the client as perceived exposure to each of these practice principles, and we hypothesized a hierarchical factor of perceived person-centered care. We use standard recommended methods, of course, and I won't belabor this, but we went through a series of steps which took about a year and a half, but of course the scale development work built heavily on existing evidence. We did not create new items. We built on what was already published, and of course Dr. Holt's work was part of this exploration. And we hypothesized an initial a priori 6-factor measurement model with 45 items, which was subjected to exploratory analyses, followed by confirmatory factor analyses, and then eventually structural equation modeling to validate the hierarchical factor structure that we had hypothesized. Of course, this was not as straightforward as taking one data set and analyzing it. And we were aiming to get a scale that was sensitive to identifying youth level perceptions or their exposure, which may be different from older clients. So we started with the pooled global sample of data collected over a 13-month period across these 3 countries and 227 facilities, with a very large sample size of about 56,352 clients who were interviewed following service delivery. We broke down the data into age disaggregated samples under 19 years, 20 to 24, and then greater than 24 years. We ran exploratory analyses on each of these data sets, followed by confirmatory analyses. And then for each age disaggregated data set, we ran confirmatory analyses for samples disaggregated by the countries themselves. Once this exercise was done, then we looked at the 3 scales for each country for the 3 ages and consolidated that into one common scale for each country where we had to choose between 2 items. We chose the items that functioned better for the younger population to provide more sensitivity to that. And from these 3 country scales, which were validated for each context, we then collated and validated a scale for the pooled global sample, which performed well across all 3 countries. And following this, we did scale refinement to identify a long form scale, an intermediary form scale, a short form scale, and just for the heck of it, a mini scale as well. So, and then we ran out of items, so we didn't do any more scales. But this is what eventually emerged as the final scale factor model. As you can see, our goodness of fit indices were excellent for the intermediary form scale, and I'll explain in a bit what each of these scales consisted of. So we had, of course, the first order hierarchical factor of perceived person-centeredness of family planning care, which had 2 sub-factors. One was perceived person-centeredness of method information. The other was perceived person-centeredness of provider interaction, which was further defined by 3 subscales on verbal communication, non-verbal communication, and of course, perceived disrespect and abuse. And as you can see, we had strong validity extracting about 72 to 80% of the variance across these scales, with somewhat lesser for perceived disrespect and abuse. We had strong reliability indices for these, indicating that these scales were very highly reliable. And eventually, we wanted to see how they mapped out to the 6 principles framework. So what we noticed was that, yes, at the provider level, the behaviors are very discrete, so they're wider in their concepts, but at the client level, the clients aren't looking at the 6 principles themselves. So what we noticed that was person-centeredness of the provider, as well as perceived understanding and involvement in decision-making. Items under those 2 factors coalesced under the nonverbal domain. Items related to communication, as well as one or 2 items from understanding and involvement in decision-making, and then perceived security of information. They sort of coalesced under the verbal domain. And then finally, we had items that came from communication, counseling, and saying yes to a safe method, which relates to method information, all coalesced under one factor of method information, which all related to technical information that was provided. Finally, the factor around perceived disrespect and abuse consisted of a series of negatively worded items that were distributed across the 6 factors. And this sort of emerged as one factor which looked at digressions from client-centered practices at the provider's level. So having mapped these out to client perceptions, the different scales that were identified for each of these, of course, the long form scale had 24 items overall, but for method information, there were 6 items. And the intermediary, we dropped 1 item depending on conceptual underpinnings to get a 5-item scale. Short form was 3, and then mini scale only had 2 items, which performed really well. For provider interaction, verbal communication, again, 6 items in the long form, which was dropped to 3. The same for a non-verbal. And then for mini scale, we took the best performing items from those. And then for perceived disrespect and abuse, we had a total set of 5 items. For the short form scale, we included selection of any 3 from the full set of 5 items, and then a mini scale had 1 to 3 items depending on what conceptual domains programs were interested in and looking at. So what does the scale look like? So this is the overall scale. I'm sorry, my eyesight is really bad. I have trouble reading this. I don't know if you guys can, but so if you look at the top one, that's perceived person-centeredness of method information, you'll see it looks familiar. It has 2 items from the method information index itself. And you'll see that we've added several other items. So did the provider ask you if you had any questions? Did the provider tell you how the method works? Did the provider tell you what to do if you wanted to stop using a method? So the working of the method and wanting to stop the method did not emerge in the older populations. Well, it did emerge, but it didn't perform as well. But for younger clients, these seem to be very important domains. Letting them know how the method works, what to do if you want to stop using the method, do you have any questions, and then what to do if you have side effects. So this we termed as the person-centered method information scale, which is sort of an advancement of the more typical non-person-centered method information index. And of course, the rest of the items, I won't go through them in the interest of time, but I'm happy to share these out. And we do have these online as part of the Beyond Bias how-to guide. Now, what's the value of these different scales? Programs are different, right? They have different needs. So the long-form scale consisted of 24 items. We looked at it as a foundational scale to be used for context-specific scale validation and refinement in new settings, as these items would sort of function similarly across settings with some differences on what different populations would consider more important. And then the intermediary form scale performed the best. It had the best statistics and fit indices and reliability, and it covered the most wide conceptual definitions across the different items. The short form scale reduced some of those conceptual elements and retained the best performing conceptual elements. And both of these could be used as an intervention. And we did that in the Beyond Bias, where the scale scores informed the provider report cards to link to the rewards pillar, which was done every quarter. And then during the Connect event, the report cards would be handed out, and high performing providers were recognized with certificates and other non-financial incentives. And they can also be used as a quality monitoring tool, whether or not we link them and provide that information back to providers in this formal report card manner. Finally, the mini scale also had good statistics to back it up. And this, of course, was only useful as a general quality screening tool, so that if you see certain, if you see that scores are low, you could go back and do a more, the bigger scale to see where the scores are dropping down. But for programs that don't have a lot of resources, implementing 6 items is quick, it's easy, and it could be done at scale. So these options were built in, and of course, for our work, we used the intermediary form scale. And to show you what a provider report card looked like, as you can see, this is the generic report card on the left. It shows the provider's overall score. It shows under each of the principles what the provider's score is, how it compares to the average in her cohort or his cohort, and then what's the model score for that particular principle. So providers could compare themselves to benchmarks, to other providers in their group, and also look at their overall score. But this is what I found the most useful for providers here. 13 to reach model score. So providers need to know what to do or what to focus on to enhance their scores. It's like opening up that visibility. You can't keep doing the full training again. So all right, your scores are low in principle 2 and principle 4. Please go and revisit that. And programs could build in those refreshers related to that. And these report cards, so this one is from Pakistan, where we branded the intervention for each country differently using cultural contexts and linking it to the HCD evidence that we had. Finally, we believe that the scale will allow programs and implementers to detect 3 critical domains related to the counseling cascade linked to the 6 pillars. They may be used individually to look at the sub-factors, or the scores may be summated across these domains within a hierarchical factor to look at whether providers adhered to the 6 principles of person-centered counseling. In effect, these scales are looking at whether clients can report on their level of exposure to this counseling cascade. And none of these items really emerged from us creating them. They're all from existing literature, so you'll see a lot of overlaps and parallels. So I believe that what Dr. Horde just presented validates our work, and our work validates their work. So I think it's really good. It adds a lot of rigor to the work we've done. And because we've done it in 3 contexts across different ages, we assume that, that these results suggest that these scales have high generalizability. And the point to note is these scales are not going to detect attitudinal bias at the provider level. They'll only detect whether clients received a certain degree of person-centered care. But we do recommend that further scale refinement is warranted to enhance the specificity for these scales and to be able to detect non-person-centered care. That's not what these scales are sensitive for. So they'll detect if you've had good care, not necessarily if you've had poor care, right? It's a nuance. So happy to talk about that. And the Beyond Bias how-to guide, if you Google that, you'll get a link to that immediately. And the scale, its operationalization, and the intervention is described in that for programs. Thank you very much.
Thank you so much, Zaire, for sharing that experience with the Beyond Bias project. It seems like a very robust development process for the whole concept of really looking at person-centered family planning care and evaluating the provider bias in relation to that. Now I'd like to move on to our last speaker, Dr. Sarah Straubinga, who is an international development practitioner with nearly 10 years of experience supporting the global reproductive health programs. And as a program manager at ThinkWell, Sarah supports a portfolio of country-based teams that implement strategies and projects related to the strengthening of health financing systems for family planning services. So welcome, Sarah.
Thank you very much. Today I'll be presenting on a study that we conducted with the Population Council and Institut Supérieur des Sciences et Populations in Burkina Faso. So I'll start by explaining that high quality of care, as many of us already know, is for the provision of family planning methods is associated with greater contraceptive uptake, higher continuation of use, and improved client satisfaction. Measuring quality of care, or QOC as I'll refer to it in short, from the client's perspective is the best way to understand what clients take away from the counseling services that they receive. Nevertheless, client perspectives are often missing from routine monitoring, despite the existence of validated QOC measures that can be easily integrated into family planning programs. Galvanizing on the success of a study conducted in India to confirm process quality measures, this study was conducted in Burkina Faso to explore how QOC measures could be integrated into the public sector delivery of family planning. Now, to offer some context to Burkina Faso, most West African governments aim to increase access to voluntary FP services and improve the quality of care received for family planning. While these governments regularly collect statistics on family planning, the QOC received needs to be systematically used to monitor family planning services in the public sector. In Burkina Faso, government commitment backed by strong international support has enabled relatively high uptake of family planning by regional standards. However, there's still much room for improvement. While the modern contraceptive prevalence rate has increasingly improved year to year, unmet need for family planning has remained largely unchanged during the same time period. Most unmet need is for birth spacing, while a smaller share of women seek to limit births. Burkina's very high total fertility rate contributes to environmental security pressures in the region. For Burkinabe women who are accessing family planning, most are accessing their services in the public sector. Using a previously validated client-centered measure in India, this study explores the structure of a 22 process quality measure for routine monitoring among women who started a new use of family planning method in public sector healthcare facilities in Ouagadougou, Burkina Faso. A secondary objective of our study was to assess the role of QOC received in continued use of a method 3 months after the client exit interview. Now, to explain what we mean by process quality measures, this is information exchanged and interpersonal relations between a provider and a client. It measures the standard of care received and reported by clients. To standardize consistency and validity in measures of process quality, Aparna Jain from the Population Council, who was the primary investigator on this study, had proposed 4 domains to measure process quality in a modified framework: respectful care, method selection, effective use of a method selected, and continuity of contraceptive use and care. The service-giving process or quality of care offered defined in this modified framework includes appropriate interpersonal relations with the client and information exchange with them to facilitate selection of an appropriate method, effective use of the method selected, and ensuring continuity of care. So at enrollment of our study, all women were asked about the quality of care they received, experiences using their method, client satisfaction with the provider, and the costs associated with their family planning received. We conducted a longitudinal study of female family planning clients who began a new use of contraceptive in 39 public health facilities between October and November 2020, and then followed up with them again in February 2021. This follow-up was conducted by phone interviews. A total of 248 women were enrolled in the study, and 218 were successfully re-interviewed 3 months later. Data collected from the interviews were used to assess the 4 process quality domains, and then exploratory factor analysis was applied to the 22 questions to assess measurement structure and reduce the items to a proxy for monitoring purposes. Additive indices were then calculated for the measures, and indices were dichotomized using a cutoff of 70% or more to represent satisfactory process quality. Finally, bivariate analysis was employed to assess how QOC varied by respondent characteristics and by modern method selected 3 months later. I'll skip over our characteristics of women enrolled for the purpose of conserving time. Now, to explain the process quality received, there were notable variations observed on individual questions across the QOC process domains. For respectful care, most women were treated well by the provider and felt that their information would be kept confidential. However, less than half reported that their questions were answered completely, and fewer reported that they were allowed to ask questions. The aspects of quality received for method selection ranged from 93% for receiving a method without any method being promoted to a low of 21% for receiving information about methods that protect against STIs and HIV. The indicators for effective use of the method selected were relatively low. Slightly more than half of the women received information on how to use their selected method and how their selected method worked. Fewer than half received information about the side effects, how to manage those side effects, or about warning signs. Most women received some information related to the continuity of contraceptive use and care. Nearly 90% received an appointment card for follow-up visit, and about 90% were informed about when to return. Slightly more than half received information about the possibility of switching. However, only about a quarter were told where to go for a resupply of their family planning method. For our factor analysis, factor loadings from examine the number of dimensions present in the 22 items to identify items that could be omitted without a substantial loss of information. Our factor loadings from the EFA are presented in this table. Nearly 90% of the total variance is accounted for by 3 factors. Factor loadings from the exploratory factor analysis, the 3 factors that formed included questions from respectful care, method selection, and effective use of the method. This is our final set of 11 questions that were reduced from the EFA. The process quality items were reduced first to 10 items across the 3 factors for respectful care, method selection, and effective use. A question about being informed of method switching did not load. However, it was included in our final list of 11 questions because it was deemed critical for programming by national stakeholders involved in the study. Bivariate associations of the score for quality of care with responding characteristics were conducted using Pearson chi-square tests for proportions. The results show that at a cutoff of 60%, more than 40% of the clients received an acceptable level of quality. However, when the threshold was set at 70%, only 33% of clients received an acceptable quality. Interestingly, bivariate analysis of QoC received by characteristics showed interesting variations. For example, 27% of women who selected an injectable received QoC at 70% or above, while women who selected the pill were more likely to receive an acceptable quality at 41%, implant at 46%, and even less for the IUD. Information during the 3-month follow-up survey included continued use of contraceptive use, method switching, and experiences obtaining the methods. In terms of continuation, about 73% used either the same method or switched to a different modern method after 3 months. Nearly 4% of women switched to a traditional method, 8% discontinued contraception altogether, 2% were pregnant, and 13% were lost to follow-up. Women who received 70% or more of the QoC measures were much more likely to continue using modern methods 3 months later than women who received less than 70%. However, we did find that this was not statistically significant. Now, there are important cost implications for what is known as the gratuité, which is a user fee exemption scheme for women and children, which was expanded in 2020 to offer family planning services free of charge. So our data collection took place about 4 months after this scheme was expanded to include family planning. Study participants' perspectives and experiences have important implications for the routine monitoring of free FP and improving quality of care for FP service provision nationally as part of a government benefit. Of 248 women who were interviewed, about 11% of women had to buy a supply such as gloves or syringes to receive their method. Some women, about 6%, were asked by the provider to provide money to receive their method, and about 7% chose not to pick a certain method because it was too expensive. Encouragingly, fewer women in the 3-month follow-up encountered costs as a significant barrier to family planning. Of women who chose to switch their method, only 4% listed costs as a significant factor for their decision to switch. And of the women who entirely discontinued use, no woman reported that cost was a factor at all in their decision to stop their family planning method. While costs do not appear to impede women from accessing their method of choice, women do encounter these costs. Of the women paying for injections, 86% paid for their method at a public facility. Of the women continuing to use the pill, 43% paid for their contraception. I will note here, though, that of the women who are paying for the pill, they sourced their contraceptives from a pharmacy rather than directly from a facility. Now, what do these findings imply? The results of the study do indicate that there are challenges in the provision of quality-free family planning, free of care in the selected health facilities, and that steps should be taken to build the contraceptive knowledge and awareness of the breadth of services intended to be free. Adoption of the measures as a standard by the Ministry of Health and their partners would be useful to increase the comparability of services over time and between regions, but typical use of the tool and the measures would be best applied on a periodic basis to a sample of facilities. Although this study was conducted in Burkina Faso, the measures could be applied to other settings in West Africa and potentially other countries at similar places in their family planning program development. Stakeholders can use the measures to monitor progress towards improving QOC for family planning provision. As Burkina Faso and other countries continue efforts towards universal health coverage, measuring QOC from clients' perspectives will help programs celebrate successes, target areas for improvement, and ultimately improve client satisfaction with services, and in turn, uptake and continuation of voluntary contraceptive use. Thank you et merci.
Thank you so much, Sarah. Ladies and gentlemen, that was really an interesting series of studies that we've just listened to. Looking at the quality of measurements and different scales of measurements for quality of care for client satisfaction, as well as provider interaction on family planning. And so what we've seen is both different, for both new and continuing users, different scales being applied, different scales of measurement being experimented with. And we had some very different scales, but the basic principles look like they're very, very similar. And that really speaks to and we even saw building on each other's methods, the building on Dr. Holt's method, and we also saw that Dr. Silva's method could be applied to other areas beyond family planning. But I'd like to really focus on the applicability of this and how we could take that forward in terms of building on each other's knowledge and looking at how we can adapt it to our own settings in a way that's very pragmatic as well. I think I'm going to open it up for questions. I know we don't have a lot of time, and I'm sure you have a lot of questions from the community because they were so interesting, the different methods and different methodologies that were used and different scales that were really aimed at measuring, basically the same issues related to quality of care and client perceptions. So do we have any questions from the group, please? Can I ask you to just take the, and if you could say who you would like to answer that question, that would be useful.
Okay. So good morning, everyone. I am a youth and reproductive health technical advisor, so I'm sure you probably know where this is headed. I very well know the Beyond Bias project and appreciate it. But I did notice that, like with Kelsey, in Ethiopia, it starts at 19 years old, and with Sarah, it started at 18. And I know, Martha, you said it, you touched on the provider bias reaching into unmarried or nulliparous women. But I'm just wondering, like, we know adolescents are highly, highly disrespected in so many of our settings, but we also know that they're one of the highest groups of first births or first pregnancies. And it can go either way, right? Married or unmarried. If you're married, you should be trying to have a kid. If you're unmarried, why are you having sex, right? So I'm just wondering, I recognize the IRB difficulties and the ethic difficulties with doing some of these studies with people less than 18 years old. But, you know, how has your validity and verification worked with Ethiopia, or excuse me, with India versus Ethiopia, where you do have younger people? And, you know, do you have scales that do ask providers about their biases against younger, unmarried, or married adolescents receiving services? So it's kind of across the board, except for Beyond Bias. So, thank you.
Thank you so much for that question. Yes, you're right. So in India, we did not do a good job of including young people in the sample. We really were focused on kind of the standard family planning client who was a married person. In Ethiopia, we did have a little bit more inclusion of adolescents, and so and one of the items is specifically, I felt scolded for my age. I think I'm not remembering the wording exactly, but essentially, did you feel scolded because you're young and trying to get family planning? The number of people who reported yes to that was relatively low, but as with all of our disrespect and abuse items, we feel that it's extremely important to keep those items in the scale regardless, because even one or two people in a sample of 300, it's incredibly important to document that that's happening. So I think you've raised an excellent point that there's a gap, I think, in what we've heard today in terms of scale development that's really focused on young people and their experiences with counseling. And I can't boast that the QCC scale of development process did a good job with that. I think in Ethiopia a little bit better than maybe some of the other settings. Yeah.
Thank you very much for the presentation. I do have one question which perhaps will cut across all the 4 presentations, but I do focus on the first presentation. My question is about the role of context in tools validation. I haven't done any tools validation, but I really want to emphasize the role of context. I'm an Ethiopian. I work at the African Population Health Research Center. I know the setting. Your sample comes from the capital, Addis Ababa, which is relatively a very privileged group. And as you have shown, some of the indicators doesn't really represent Ethiopia. Like you have less than 10% of women of reproductive age with secondary education overall, but here it's close to 60%. So with that, I really want to see how that influences your result. Does that tool really work if I take it to another region? We have indicated that there was good consistency across the 3 sites, strong symmetric properties of the tool, but let's see your reflections on how well it works in a rural setting. Thank you.
Thank you so much. Yes, you're absolutely right. In Ethiopia, we did focus on the capital, both with the qualitative work and the scale validation. So you're right. We don't know the extent to which the scale would both reflect what people really want in different settings in Ethiopia, and also whether it works from a psychometric standpoint. So I think this speaks to a larger issue in scale development, where we always struggle to balance the need to make things context specific, and also, you know, move on and have a scale that can work in some places. And so you're hitting on that tension. And in our project, you know, this is just sort of the resources that we had and the feasibility that we were able to do. But you're absolutely right. In fact, we did collect some data from 2 other regions in Ethiopia, but we didn't get a sample size that was high enough to include in the validation. So anyway, we tried, but ultimately failed to get a high enough sample to be able to include a regional differentiation. But thank you so much for your question.
Can I ask Zaire to also answer that, because he's had a lot of experience with the contextualization with larger sample size
So,
in young people?
thank you, Annette. You're absolutely right. I don't think there's any perfect sample for scale development that anyone's ever done. All samples are going to have gaps in them. I think for a lot of us working in quality of care, we are restricted in terms of who is sampled into the study. As you know, even within our sample, we had a category for young women and girls under 19. But those samples were not as large as the other age groups, right? So we are limited in terms of the larger effect of social determinants on who ends up at the facility. We know there are disparities. We know there are barriers to care. So a lot of these studies are looking at facility-level interaction between providers and clients. And if we want to look at those determinants, that happens at the community level, and there's no quality of care counseling happening there. So it's already limiting young people's access to facilities. So that's just a reality of the field we're in, right? We can only sample and work with who gets to the facility. For programs, there are programs which are trying to improve access to facilities, which is a different program area. So you're absolutely right. There will always be problems in terms of being able to apply a scale uniformly. I don't think there are very many scales that are able to do that. Hence, as part of our work under Beyond Bias, we did the long form 24-item scale, which could be applied to different contexts and then reduced in terms of what items work best for that population. So your point is well taken. We're just limited by the realities of scale development and the context we're working in.
Could we ask the gentleman here, and then I'll ask you as well.
Thank you. Matt Bogshall from ThinkWell. I'd like just to reiterate the chair's question, actually, and ask all the panelists. Clearly, there's been tremendous progress towards validating these technical instruments and a degree of alignment, I think, emerging from the discussion. However, taking a health systems perspective, perhaps, can I ask what success you have had in the countries, in the settings you've been working, in engagement with national governments, national family planning programs, to actually use these instruments that have been developed, and perhaps some of the pragmatic questions about cost, applicability, frequency, sample sizes, and how that might be taken up. Thank you.
I think everybody.
I can jump in if you'd like. Yeah, sure. So in Burkina Faso and Tanzania, all the facilities were public sector facilities under Beyond Bias. In Pakistan, all the facilities were private sector facilities. Now, we had public sector ownership of the work, of whatever was produced through this work. Some of this has been adopted in all 3 settings, bits and pieces of it. But as you can imagine, with data systems, just getting one indicator into the system is a challenge. I mean, just for example, we even right now with the data systems at the district level or at the government level, we don't even know what services are delivered by the private sector. Even that isn't visible. So trying to understand, what quality of care metrics are being reported we're still a ways off. I think there needs to be a lot more investment in capacity and market systems and also this isn't going to happen anytime soon. I think it's going to take a long time before governments are at that level where they can do these wide information systems which capture all of these domains. So I think that's a challenge. You're absolutely right. Bits and pieces get adopted, not in its entirety, and that's where the advocacy comes in, and the evidence and the publications and all of that come in. It's a process.
Yeah. So just to reiterate what Zahir has just said, I think for the provider side, there are no systems that in place in Togo that these questions could be plugged into that could systematically collect data that could be useful for programs and as well as district level or national level government. So I think that at this stage, it's a matter of advocating for the need to understand what some of the behavioral determinants for provider behaviors is, and to prove or to demonstrate that these data can be useful. So I think that's the stage that we're in, also with the projects that we partner with that have provider behavior approaches or interventions, is advocating for the need to have these measurements and use them.
And I can speak somewhat to the experience of Burkina Faso with adoption of this tool. So to my knowledge, the tool and the findings of this study have not yet been adopted by any program. Speaking specifically to the experiences of the Gachite, which I referenced in my presentation, we would not recommend that this tool be integrated into the routine monthly monitoring of the scheme, simply because it's too intensive to be carried out, but it would be certainly much more valuable to be done on, say, a quarterly or an annual basis. The other concern that we have specifically with this tool and the Gratuite or another family planning program in Burkina Faso is that it should not be used to be linked to any kind of financial incentive as part of a national scale strategic purchasing initiatives, and that would create some misalignment in implementation of the scheme and the functioning of the delivery of family planning services. If you would like to hear more about the use of family planning services delivered through the Gratuite, you can hear more about this from my colleague Marie-Jeanne Foss, who's in the audience today later this afternoon. Thank you.
Excuse me, Annette, can I just add something very quickly of relevance? So, Matt, if you noticed, we did a mini scale, 6 items. The idea behind that was we already have the method information index in the DHS. Moving from 3 questions to 6 within the DHS once every 5 years is potentially doable, and it would bring in a person-centered perspective at the system level. So that's one of the recommendations that came from that. I don't think it's going to happen at the facility level, though, anytime soon.
Hi, thanks. My name is Ann Fitzer, and I'm with the Momentum Country and Global Leadership Program at JPIGO. And I actually have a follow-up question to both Matt's point and yours, because I'm very interested in thinking about what quality measures could be used by QI teams within the health systems themselves, as opposed to external program implementers parachuting in, if you will. And I wanted to ask you about that mini scale and whether you think that QI teams working either at the facility level or at the district level could potentially apply it, whether 6 items is the right amount, and how you would see what their interpretation of the results and how actionable the results. Like, could the answer to that scale lead them to then think about their own practices and performance and make changes themselves without sort of a lot of external analysis? Thank you.
Do you want to go first, Matt? Okay. There's a lot of movement around social accountability, community engagement, client feedback mechanisms. I think one of the major funders for that work is USAID. In multiple programs, they're doing that. As I said, there is still no perfect solution out there. But for QI teams, I mean, we've been exploring different ways to make this happen outside of public health and family planning. Folks are doing a wonderful job at getting client feedback. Whether it's Uber or it's banking systems or whatever, they've got these little things. You're at the teller, they've got a little screen, you've got 3 stars, 4 stars that you give. They're looking at those systems already. They've integrated them. I think we have lessons to learn from the private sector in that regard. Of course, we are limited by resources. But if QI teams at the district level wanted to assess it, you know, you don't need very large sample sizes to do this kind of assessment because the scales are validated, so you can interpret those scores. So if QI teams were to visit a random selection of facilities over a 3-month period, and they have a sample, whatever the number may be, those scales can be interpreted in an aggregated scores or even looked at individually. I think there is room for that because that is happening. They do visit facilities. And organizations like Murray Stopes, for example, have these quality assurance visits. So these supervisors, they go to the facility, and part of those supervisory visits is to talk to a few clients coming out, right? 2 or 3 clients during that visit. That's entirely doable. It's just about often programs are measuring satisfaction, which is a very poor measure to begin with. It's not interpretable. But to add to that, even person-centeredness of counseling is only looking at that interactional element. Perceived quality has 4 other dimensions, or maybe more, right? So those are still not included in these scales. So how do we decide which is the best dimension to assess? I think quality of counseling is right up there, but then there are other domains as well that fall within perceived quality.
Thank you very much. And ladies and gentlemen, that brings us to the end of our session. We've had a really, really rich discussion on these different methods that are and different scales and the applicability of them, both in the monitoring in the health system setting, but also in terms of with the QI teams, but also the applicability that, or the gap that there is in relation to young people and the need to think about that in a lot more depth on how we can really take that into account. And it was really good to hear about the different context, settings that we need to really think about and how we can adapt them in ways that are really applicable for the providers to bring about change. And so it was really good to see the performance card, for example, in which there's feedback to the providers that allows them to think about the person-centered approach that they're taking. So ladies and gentlemen, it's been a rich discussion, and I thank you for your attention and thank you for being here. And
Thank you so much, Anush. This is fun.
Thank you.
Yeah.
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 Perfect number of people.